This meeting is being recorded.
Hi, everyone. Thanks for joining the didactic series for today. I wanted to introduce Dr. Kurtz, who we all know. We're very, very lucky to have him be presenting Approach to Simple Acid-Base Disorders. As you know, he's the chief of the Division of Nephrology at UCLA and factor chair in molecular nephrology, as well as a member of the Brain Research Institute. And he wears many, many hats and has been a mentor and colleague for most everybody who's graduated from UCLA. And so we're very lucky to have him. Please mute yourselves, and thank you, Dr. Kurtz.
Thank you, Vandana, for that kind introduction. Today I'll be talking about how clinicians should approach the simple acid-base disorders. I won't be talking about the complex acid-base disorders. Today we'll leave that for another time. But before getting into the clinical components of this, I want to talk a little bit about some chemistry, and in particular the chemistry of the bicarbonate buffer system, because this is the most important buffer system in the body, and it's unique because unlike other acid-base buffers, the acid component is volatile and can change with changes in lung ventilation and respiration. So on top are all the components of what we call the bicarbonate buffer system. Everyone's familiar with bicarbonate, but there are other components also that a clinician should be aware of because they can affect the blood chemistry, and in particular the acid-base status. So on the left here, this CO2 represents carbon dioxide, which can either be in a gas or it can be dissolved in a solution. We all know this because when we ingest carbonated beverages, it's because this gas is dissolved. Water we know the symbol of, and when these two entities combine, they form something called carbonic acid. Carbonic acid can then split up into a proton and bicarbonate, but it's not well realized that the bicarbonate can further break up into another proton and what we call carbonate. So if you look at just the species that have a carbon atom attached to them, there's four of them. There's carbon dioxide, carbonic acid, bicarbonate, and carbonate, and they're all in equilibrium. So that's the first point. Now, in the second line is something called TCO2 here on the left, and this stands for the total carbon dioxide content of blood. Now, it's a poor term because it really refers to all the components in this buffer system that have a carbon atom, and clearly they're not all carbon dioxide. But this is the term that evolved. So we call this the TCO2, and this is what we measure when we get the blood chemistry and we get the sodium, potassium, chloride. It's not bicarbonate, as many renal fellows say. What we measure actually is the total species that have a carbon atom. So it really represents bicarbonate, carbonate, carbonic acid, and dissolved CO2. Now, because quantitatively most of the TCO2 is bicarbonate, many people erroneously interchange these two terms. But for the fellows, as of today, you should stop calling this bicarbonate. Bicarbonate is what we calculate when we get a blood gas. We don't have a way to measure bicarbonate. So it's a calculated number, and it's calculated based on the Henderson equation, which I'll show next. So remember, what we measure is this, and what we calculate is this. Now, in most clinical situations, they're very close because the carbonate and the carbonic acid are micromolar, very small amounts. The bicarbonate, as we know, is around 24 or 25 millimolar. And the dissolved carbon dioxide gives you roughly another 1 millimoles per liter. It's actually 0.03 times your PCO2. And if your PCO2 is 40, this comes out to 1.2 millimolar. This varies with whatever the PCO2 is. It's always 0.03 times the PCO2. So if this is 1.2 and this is, let's say, 25, this will be 26. Now, what this also implies is that the total CO2 must always be greater than the bicarbonate that you calculate from the blood gas. Now, this is only true if it's the same type of blood, and we'll talk about the difference between venous and arterial. But assuming they're both venous or they're both measured from arterial blood, you can never have the bicarbonate that's calculated from the blood gases coming back at a number higher than the total CO2. If that occurs, you know something's wrong. Either this was measured incorrectly or this was calculated incorrectly for some reason. This must always exceed the bicarbonate. And I don't know if you remember, but in the metabolic alkalosis case that I presented a short time ago, for some reason, the venous bicarbonate came back higher than the total CO2, which was impossible. So there was something going on there that was never understood. So that should raise a red flag if you see it. And it's important because you don't want to start thinking further and making an acid-base assessment unless it does hold true that this is slightly higher than this. Now, this can be a lot higher than this if your PCO2 goes up. So when you have a patient with severe respiratory acidosis, this is not going to only be 1.2 higher, it can be 3 or 4 millimolar higher. Bicarbonate's still the same. It's just that now your total CO2 has increased. So you just have to be cognizant of these subtleties. Now, below that is a short form of the Henderson-Hasselbach equation. There's no logs. Sometimes this is called the Henderson equation. But what it shows you is that the proton concentration in a bicarbonate buffer, it doesn't have to be blood, it can be a bottle of Coca-Cola, is always 24 times the PCO2 over the bicarbonate. Now, this equation is important because it also represents organ physiology. The PCO2 is determined by the lungs, and the bicarbonate is determined predominantly by the kidney, and I'll talk about that in a little bit. In addition, this is important because this is how the blood gas machine calculates bicarbonate. The blood gas machine knows this equation. And as I said, it's calculated. And the way it does that is there's a pH electrode in the blood gas machine that measures the pH and then converts it to hydrogen ion concentration, depending on the equation that's in there. You can have different forms. You can have a log equation, then it doesn't have to. But it measures this, and it also measures the PCO2 with a PCO2 electrode. So the blood gas machine makes two measurements, a measurement of the PCO2 and a measure of the pH. And then it calculates the bicarbonate. Now, this will always be true. Some people have the erroneous thought that because the bicarbonate's calculated, somehow demotes it to a lower level. That's absolutely not true. It would be equivalent to having measured it if we could, assuming that the PCO2 and pH are measured correctly. So if you have an erroneous pH measurement and an erroneous PCO2 measurement for some technical reason, the electrode's not working or it wasn't calibrated properly, of course the bicarbonate will come back with a number that doesn't represent reality. But assuming that the PCO2 and the pH were measured correctly, the bicarbonate that you get will be a valid number and should be treated as such. Now, normally, not with the units involved, because the units are obviously different here. The PCO2 is in millimeters of mercury, the hydrogen ion concentration is in nanomoles per liter, it's very small, and this is in millimoles per liter. But ignoring the units, numerically, the left side equals the right side. So 40, which is the normal hydrogen ion concentration, 40 nanomoles per liter equals 25, this constant times the PCO2 of 40 in millimeters of mercury divided by the bicarbonate concentration in millimolar. And this is nice also because when you get the numbers back, you can always check the clinical lab by putting the numbers in and just making sure that the right side equals the left side. Now, it's important that it's the same type of blood, as I mentioned, and I'll talk about it in a minute. There's a difference between venous and arterial blood, and so you can't mix those two or you're going to get the right side not equaling the left side. But assuming it's the same type of blood, then it follows that this equation holds, and is a nice check on the lab. We don't have this in other areas of medicine. We can't check whether the bilirubin and CPK and SGOT, let's say, are correct because there's no equation equating them. But with these numbers, there is. So it's unique in that sense, in that we can check whether the numbers are correct before we will go on to start thinking why they might be abnormal. Now, the other important point to realize that some people forget is that this equation, this identity between proton concentration, the PCO2, and bicarbonate holds true irrespective of whether you have an acid-base disorder or not. It doesn't matter. Even in the presence of an acid-base disorder, the right side must equal the left side. Now, the other thing that we face clinically is that in order to check this equation and think about the hydrogen ion concentration is a bit hard, because what evolved was for the clinical labs to give us back pH. This evolved for thermodynamic reasons, where the pH electrode gave the pH rather than the hydrogen ion concentration historically, as people started understanding acid-base chemistry in a more detailed way. And it's unique. We don't have the negative log of the sodium concentration or the potassium concentration. We deal with the concentration in millimoles per liter, and it could have evolved that we would be getting the hydrogen ion concentration back at 40 nanomoles per liter, but it just never occurred that way. So we get this back, and in order to check the equation, or if you want to know intellectually the hydrogen ion concentration, you have to be able to convert the two. And an easy way for clinicians to do it is just remember that a pH of 7 is 100 nanomoles per liter. And then what you do is you write all these down on the left, 7.1, 7.2, 7.3, 7.4, et cetera, and you just keep taking 80% of the previous number, and it works out very closely. So 7.1 is 80, 7.2 is 64, et cetera. And this covers most of the range that you're going to need clinically. And then you can just interpolate in between. So, 705 would be close to 90, something like that. So it's just a quick and dirty way. Of course, now with iPhones and having a calculator on your phone and algorithms, you don't have to do this mentally. Now, the other important thing to realize is that men and women don't have the same normal numbers. And the reason this is important is because in assessing clinical acid-base disorders, we are always comparing the numbers to what the normal should be. We do that because we typically don't have what the normal was in our patient prior to developing the acid-base disorder. So, if we have previous normal numbers in our patient, that's the best thing to compare to. But typically we don't, so we have to always compare what our new patient has with the population mean values. And so in a male, we have the numbers that we typically think about. So the hydrogen ion concentration is 40, and the PCO2 is 40, and the bicarbonate's around 25. But females tend to have a lower PCO2. It's not 40, and the bicarbonate is not 25. And unless you realize this, you're going to miss subtle acid-base disorders in females, because you will not be assessing the difference from normality properly. If you use these numbers in a female, you're going to make the wrong diagnosis, and you're going to miss some diagnoses. So a PCO2 of 40 in a female is not what you would typically see, and means there's something going on. So this is sort of in the steady state, but young women aren't in the steady state, and that's because they ovulate. And it's known that at the time of ovulate, around mid-cycle, when the progesterone goes up, that stimulates the respiratory center, and the ventilation increases, dropping the PCO2 further. So, and people actually used to use the PCO2 measured daily to tell when a woman ovulated. There is this dynamic change that occurs also, and you have to be cognizant of that, because that is normality in that particular individual. Every month at mid-cycle, women are developing an acute respiratory alkalosis, and you just have to be cognizant of that. Now, the other difference is when you look at arterial versus venous blood gases. They're not the same, And venous gases are a very nice way to assess a person's acid-base status if you don't care about their PO2. And it's also a nice way of following patients dynamically, both if they have a change in clinical course from the acid-base side of things and to follow therapy. You just have to be aware of the difference. The pH is a little bit lower, the PCO2 is a little bit higher, the bicarbonate's a bit higher. And these are typical numbers in a normal individual, a normal male on the venous side. Remember, the women have different numbers on the venous side, but the direction is the same. Now, just as far as background, the PCO2 was not only used to tell when a woman ovulated, but it was used to tell at the bedside what a patient's cardiac output is. And it still could be used, it's just no one does it. And what you do is you take the venous minus arterial PCO2. And normally that difference is, as I showed here, about 3. But as that difference increases, the cardiac output drops. And it has this non-linear relationship. So the higher this value, the worse the cardiac output. And it's a very nice indirect way, if you're wondering what's my patient's cardiac output, to get the venous and arterial blood gases and subtract the 2 PCO2s. No one does it anymore, but the relationship is still valid, and you might want to try it in someone who you can't get a cardiac output and you really need to know clinically, because it's going to alter your management. Now, just looking at those numbers in more detail, the PCO2 is kept constant at around 40. And that's like everything else that we deal with in nephrology. The input and the output are equal. Here we're dealing with a production and an excretion from the body. So the production occurs in our mitochondria, and every day about 20 moles of carbon dioxide are produced in the Krebs cycle. And obviously that can't be allowed to occur without it being excreted, or we would have a marked elevation in our PCO2, a marked respiratory acidosis, and the ensuing consequences. So it just turns out that we have a very sensitive system in the brain to assess what the PCO2 level is, to keep it at that level, and to make sure that the excretion is modulated accordingly, so that at any point in time, the PCO2 is kept around 40. So if there's changes in production, that will cause simultaneous or almost simultaneous changes on the excretion side. If there's decreases in production, the excretion will go down. So they're coupled, thereby allowing the PCO2 to stay constant. Now, what about the bicarbonate? So the PCO2 is in a sense easy. We have production and excretion. The bicarbonate story is a bit more complicated. How does the bicarbonate stay at 25? Well, there's 2 factors that would tend to make it not be 25 that the kidney deals with. So it's not the lungs that determine what the bicarbonate is. It's the kidneys that have worked out a way, despite certain things occurring, that the concentration of bicarbonate is able to stay at 25. The first problem is that the bicarbonate's freely filtered. It gets through all of your millions of glomeruli. With a GFR, let's say, of 180 liters a day, that might be a little on the high side, but let's just say that's true. With 25 millimoles coming in each liter of fluid coming through the glomeruli, that works out to about 4.5 moles a day of bicarbonate are coming through all our glomeruli, which is roughly the amount of bicarbonate in a box of Arm & Hammer baking soda that we're all familiar with. So this is how much bicarbonate comes through our glomeruli in a day. And if that continued to occur with nothing else happening in the kidney, you would excrete all that in the urine in about 4 hours, and your blood bicarbonate would be 0. So clearly in mammals, this cannot be allowed to occur at all. And what has evolved is a set of complex, what I call molecular transport machinery, that allows the bicarbonate not to be excreted in the urine. And what we have are systems that reabsorb the bicarbonate. And the most important site is the proximal tubule of the kidney, where we have bicarbonate coming through the glomerulus, and on the so-called apical membrane, or what's also called the luminal side, or what's also called the urine side of the cell. We have this transport protein called NHE3, which is one of the NHE proteins. There's 8 of them. N stands for sodium, H stands for hydrogen, E is exchanger. It's a sodium hydrogen exchanger. One sodium goes into the cell in exchange for a proton. And this is the protein that's found in all mammals on the apical membrane of the proximal tubule. In addition to that, there's something called a proton Atpase, which is actually not one protein. It's made up of many proteins. But these two processes, predominantly NHE3, are responsible for binding protons to bicarbonate in the lumen. So there's really no direct way of taking bicarbonate from the filtrate and bringing it back into the cell. It's this indirect process. There's some studies from a few years ago suggesting there's more of a direct way. There's a sodium bicarbonate co-transporter perhaps on the luminal membrane that plays a little role, but the predominant way we get bicarbonate into the cell is an indirect process that requires proton secretion. And I'll talk about how the bicarbonate gets back into the cell in a minute. Now remember, NHE3 is also the protein that SGLT2 inhibitors are thought to inhibit, which is why they have some of the phenomenology that they have. So NHE3 is also in the SGLT2 inhibitor. How it inhibits NHE3 is not clear, but it's in that literature also, as many of you know. So the proton binds to bicarbonate, forming carbonic acid. This again is just the bicarbonate buffer system, and you're shifting the equilibrium because you've got protons coming in here, driving it in one direction towards water and carbon dioxide. Both the water and the carbon dioxide enter the cell on this aquaporin called aquaporin 1. This reaction of carbonic acid to water and carbon dioxide is catalyzed by one of the carbonic anhydrases, and there's many. This is carbonic anhydrase 4, and it's unique in that it's attached to the luminal membrane. It's not going in and out of it's not a transmembrane protein. It's actually attached to something else called a GPI anchor, and it's actually it's the GPI anchor which is in the membrane. The carbonic anhydrase floor is actually bound to it and floating free in the solution here by the membrane. So it speeds this up. It doesn't cause it to occur. It would occur anyway. It just occurs much more quickly because of the carbonic anhydrase 4 there. So the water and the carbon dioxide get back into the cell, and then you just have the reverse reaction occurring. Again, the bicarbonate buffer system driving it the other way. First, the CO2 and water reform carbonic acid, just the opposite that occurred in the lumen. It's catalyzed by another enzyme, which is in the cytoplasm called carbonic anhydrase 2. And in fact, there are mutations in this carbonic anhydrase that lead to proximal and distal RTA. We won't talk about that today, but the carbonic acid then breaks up into a proton, initially bicarbonate. The bicarbonate breaks up into another proton with carbonate, as I showed in that one of the first slides. So in the end result is you make 2 protons and a carbonate. So the proton one of the protons can recycle here, the other here. So you can think of it, the proton is really just recycling, but now what you've done is you've taken the bicarbonate into the cell and formed carbonate. The carbonate leaves the basolateral side into the blood on this protein that our lab has worked on for a number of years called MBCE1A, which transports 1 carbonate and 1 sodium into the blood. And that's how bicarbonate gets from the urine side to the blood side. You can see that this hole carries 2 negative charges and this carries 1 charge. So this thing actually carries 1 negative charge when it's transporting, and it's driven by this electrical gradient, which is on the basolateral membrane. That's generated by the sodium pump and also what's called a potassium diffusion potential. When potassium moves from the cell to the lumen, it contributes to this membrane potential here. But the bottom line is that this transport is driven by the electrical gradient, and when you don't have this electrical gradient, this just stops. The chemical gradients are actually to go into the cell. So if there was no electrical gradient, sodium and carbonate would actually enter the cell because their concentrations in the blood exceed their concentrations in the cell. So this electrical gradient allows the sodium and carbonate actually to leave the cell against their chemical gradients. So that's how we get bicarbonate or carbonate back into the blood. Now, the second thing the kidney has to confront is something very different. It has nothing to do with the filtration and the reabsorption of bicarbonate. It has to do with the fact that every day from our diet, we're making acid, roughly 50 milliequivalents of acid a day. And it's actually the liver that makes these protons from our diet. And if nothing else happened, it's the same bicarbonate buffer reaction. The proton will combine with bicarbonate to make carbon dioxide and water ultimately. Carbon dioxide we would excrete, but now we have a lower bicarbonate concentration in our blood. Same thing that happens with lactic acidosis, where the proton is coming into the blood, or ketoacidosis, where the keto acids are coming into the blood. It doesn't matter what the source of the proton is. The same reaction occurs and would create a metabolic acidosis. And clearly that's not occurring. Our blood bicarbonate is staying at 25 despite our diet. If nothing happened, our bicarbonate concentration in our blood in about 2 weeks would go to 0 from this process. Now, it turns out when you look at different foods, they have different abilities to make acid. Cheeses, egg yolks are very strong in their acid production, whereas spinach and raisins are on the other side. They actually make net bicarbonate. And it has to do with the amino acids. Egg yolks and hard cheese have glutamic acid and aspartic acid more commonly, and where spinach and raisin have base amino acids that when they're metabolized make bicarbonate. So it just depends on the type of amino acid which is present, and that's what determines this sort of spectrum of acid and base production. So what do we do with this? We have 50 milliequivalents of protons coming into the body in the form of hydrochloric and sulfuric acid. And it turns out the kidney actually makes additional bicarbonate that has nothing to do with the bicarbonate that it reclaimed from the glomerular filtrate. This is new additional bicarbonate that the kidney makes to match the daily hepatic proton load. It's the inability of the kidney to do this that causes the metabolic acidosis in CKD or ESRD. The kidney loses the ability to make new bicarbonate. It has nothing to do with bicarbonate reclamation, although that also can occur. Impaired bicarbonate reclamation can occur also, but we call that RTA. This is a problem with bicarbonate generation. Now, how does the kidney make bicarbonate? Well, on the next slide, that will be shown. Just again, to reiterate that the proton and bicarbonate make carbon dioxide. We excrete the carbon dioxide, so everything is fine. So how does the kidney make new bicarbonate? Well, it makes it from alpha-ketoglutarate. I talked about alpha-ketoglutarate in the metabolic alkalosis talk because it's one of the intranephronal signals that stimulates pendrin, bicarbonate secretion in the beta intercalated cell. But it's also a key chemical in the Krebs cycle. And so alpha-ketoglutarate is the source of new bicarbonate. Now, where does it come from? It comes from glutamine. Glutamine can get into the cell on the apical membrane. It can also come in from the basolateral side, but there are a series of reactions that occur in the mitochondria that make alpha-ketoglutarate, and alpha-ketoglutarate then is converted to, the carboxyl groups are converted to 2 bicarbonate ions, which go to the renal vein, and that's how the kidney makes the new bicarbonate. Now, there's a problem with this reaction in that it's not only bicarbonate which is made, but also 2 ammonium ions. Now, why do we care about that? We've made our new bicarbonate. Well, making 2 ammonium ions is a problem because if the ammonia derived from glutamine were also transferred to the renal vein with bicarbonate produced from alpha-ketoglutarate, you would consume the bicarbonate in the urea cycle. And that's a very important concept, that if there's ammonia accompanying it, then the urea cycle in the liver would take up the ammonia and bicarbonate to make urea, and you wouldn't be left with the bicarbonate now to match your daily proton load from your diet. So if you look at the urea cycle, urea is really made from 2 ammonium and 2 bicarbonate ions. And so you cannot have ammonia coming with that bicarbonate, but we do. Otherwise, you would just be turning the glutamine into urea and you would be doing nothing for your acid-base status. Well, it turns out the kidney is able to not send all the ammonia that it made into the renal vein, because if it did, it would be a futile cycle. And it turns out the kidney puts all the new bicarbonate into the renal vein. And the ammonia, it puts some of it into the renal vein. In a normal human being, 40% of the ammonia it makes goes into the renal vein and then consumes 40% of that bicarbonate, but you're still left with 60%. 60% goes into the urine, and that's a very complicated system, which is a separate lecture, how ammonia from the proximal tubule ends up all the way in the collecting duct. And it turns out the nephron has a whole series of transport processes to allow a fraction of the ammonia it produces to go into the urine, and that's what we assess when we assess the urine anion gap or the osmolar gap divided by 2 that I'll talk about. We're assessing the fraction that went into the urine, but you have to realize that's only part of what the kidney made. And you can typically assume it's around 60% in normal people. And so you can back calculate what the total production of ammonia must have been. Okay, now let's get from this background now to how to make an acid-base diagnosis clinically. And there are a number of different ways to do this, but what this approach entails is the so-called Boston approach from the 1960s, which has stood the test of time and allows you to assess the patient accurately. So the first question you want to focus on when you're assessing someone's acid-base status is don't get hung up looking at everything. Make your mind focus on one thing, and that is the bicarbonate concentration. Not the pH, not the PCO2, just look at the bicarbonate. Now, you may not have a venous calculated bicarbonate or an arterial calculated bicarbonate, so you can use the total CO2 here, as I mentioned, in most situations, because the bicarbonate concentration is only 1 millimole per liter less than the total CO2. So ask yourself, is it down, normal, or up? If it's down, you have 3 acid-base diagnoses which can lower the bicarbonate without knowing anything. It's either a metabolic acidosis, which everyone remembers, but it can also be an acute respiratory alkalosis or a chronic respiratory alkalosis. The way we distinguish which it is not by looking at the pH. And if you look at the pH, you're going to forget all the acid-base rules and you're going to miss mixed acid-base disorders. So what you should focus on next is, once your mind has decided, is it down, normal, or up? The next thing you look at is the change in bicarbonate to change in PCO2 from normality, because each of these disorders has a different proportion. If it's metabolic acidosis, the change in bicarbonate to change in PCO2 is 1.2 to 1. I might add, in all of these, both the bicarbonate and the PCO2 change. And in all these 3 disorders, they all change in the same direction. They all have in common a decreased bicarbonate and a decreased PCO2. That's a very important point to remember. It's not just in one and not the others. So they have the same parameters changing in the same direction. And the only way we can distinguish which of the 3 it is numerically. So in acute respiratory alkalosis, the ratios for every 2 change in the bicarb, PCO2 changes 10, again, in the down direction. And chronic respiratory alkalosis is shown here. So what you do is you plug your patient's numbers into one of these 3 things. Well, first you calculate what your patient's numbers are, how much did the bicarb change and how much did the PCO2 change, and then you say which of the 3 most closely matches it. Now, if it's clear that neither of the 3 match it, you have a mixed disorder a priori. You don't have to even think further, assuming the numbers are accurate. It can't be one of the 3, it's a mixed disorder. But assuming it's one of the 3, that's the one you pick. Now, it can be a little bit off, which is where the art comes into it, because that's more of how much difference from one of these 3 things are you going to say really represents a mixed disorder. And a number of things come into that, which I'll talk about in the lecture of the mixed disorders. But assuming it does come very close to one of these three things, then it's easy. It is that particular one. Now, remember that what you're assessing is the change from normality. So the question is, what is normality? Now, it's best if you have the patient's prior numbers. That would be your norm that you're comparing the abnormal numbers to. But if you don't have previous numbers in your particular patient, you have to use the population normal numbers. So remember the male-female differences. Now, what if the bicarbonate's increased? Again, it's one of three things: metabolic alkalosis, which everyone remembers, or acute respiratory acidosis, and chronic respiratory acidosis. And again, the change from normality of each of these things has a predictable ratio, which you have to memorize. And if it falls into one of these three things, that's your diagnosis. If it's not one of these three things, you have a mixed disorder. But again, it's the same thinking. Look at the bicarbonate. Is it up, down, or normal? Then calculate the change from normality. And again, do not look at the pH when you're assessing this. In fact, you never have to look at the pH when you're assessing acid-base disorders. It's only somewhat confirmatory. But again, the pH is a net result of a whole bunch of different acid-base disorders that might be present. And so it really doesn't help you define what each of the separate disorders are. And again, if you rely on it, you're going to never learn these rules, and you're also going to make mistakes as far as when you have complex mixed disorders. Now, the other thing to just keep in mind, and this is a chronic relationship now, is that the PCO2 and bicarbonate, even though they have this proportion in chronic respiratory acidosis, as I just showed, for every 10 increase in the PCO2, the bicarb goes up about 3.5. And in respiratory alkalosis, for every 10 chronic respiratory alkalosis, for every 10 decrease in the PCO2, the bicarb drops a little more by 5. Remember that this is a continuum. And in the normal range, if you just take 1,000 individuals, not everybody has the same PCO2 and bicarbonate, you'll get this sort of relationship here in the so-called normal range of 0.4. So it's sort of an easy way to remember the chronic respiratory acidosis rule, chronic respiratory alkalosis rule, that there's this number in the middle that defines normality. But in general, there's always a relationship chronically between an individual's PCO2 and their bicarbonate. Now, once we make a diagnosis, we have further clinical subdivisions that you must make. Now, everybody knows metabolic acidosis is divided up by the normal anion gap or elevated anion gap. But we have to remember that each of them is divided up into two subdivisions. Metabolic alkalosis, we divide up by its response to chloride. There's one group of patients where we give chloride and the chloride will just come out in the urine and the bicarbonate will stay elevated and we'll do nothing for the acid-base disorder. There are other individuals where we give chloride and everything corrects. Respiratory acidosis, we don't divide up by anion gap, we don't divide up by chloride, we divide it up temporally. And we call the two subdivisions acute or chronic. Respiratory alkalosis, we also divide up temporally, acute or chronic. We use the word compensated also in further thinking about both metabolic acidosis and alkalosis, which we'll talk about. We do not use the word compensated in the respiratory acid-base disorders. We also don't use the word primary or secondary. A lot of people do that, and that's not correct. We don't call something a secondary respiratory alkalosis when we're talking about the compensation in metabolic acidosis. And we don't call the subdivision of these two things primary either. If it's a real respiratory acidosis, we don't call it a primary respiratory acidosis. If you're using the word respiratory acidosis, you're saying it's primary, so you don't need to use the word primary. It's redundant. Now, what about the anion gap? The anion gap simply implies that if you add up all the known positive charges that we measure in the blood, they will equal all the known negative charges that we measure. Now, there are things that we don't measure, and so it's a bit complicated. In reality, I could have put here unmeasured cations, and here plus unmeasured anions. OA is organic anions like lactate, acetoacetate, that kind of thing. But if we just take the things we typically measure, these are things we could potentially measure, we don't. If we take the things we practically measure in the real world, it's really only a few of them. It's the sodium and the chloride and the bicarbonate. This could be total CO2, remember, if you don't have a number from the blood gases, calculated number. That will equal, we can lump everything into unmeasured. So this would be unmeasured anions, which includes phosphate, sulfate, organic anions, and this would be unmeasured cations, which includes IgG. Remember, IgG is positively charged, magnesium, calcium. To the extent that we measure it, it wouldn't be in here, but we don't measure these things. Well, we might measure calcium and magnesium, and they could be put into your equation too if you wanted. We don't even put potassium here normally, and we could. Now, normally if we do this and measure only these numbers, we get an answer of 11, which means that the unmeasured anions minus the unmeasured cations is 11. Now, albumin is a big part of this unmeasured anions because of the type of amino acids it has. It's negatively charged. And what you can remember is if the albumin changes by 1, the anion gap changes by 2.5. So if, let's say, you have an albumin going from 4 to 3, your anion gap will be 11 minus 2.5. It's not going to be 11 anymore. So the anion gap drops as the albumin drops. And remember that because sometimes you have, a liver patient with an albumin of 2 or a severely nephrotic patient. Well, their anion gap can be 7 or 8. Doesn't mean there's anything going on. It's just they've lost albumin. On the other hand, the organic cations can go up, such as in myeloma, where the IgG concentration goes up, and that can also lower your anion gap. It's not because the unmeasured anions drop, but because this went up. Now, the other factor which people forget about is that the charge on albumin, or the charge that albumin contributes, is not just due to its absolute concentration. It's also affected by the pH because albumin is a buffer and it's protonated or deprotonated. And as you protonate albumin, you will lower its negative charge. And as you deprotonate albumin, which occurs when the pH in the blood goes up, you will increase its charge. So if you think about it, in a metabolic alkalosis, where the pH goes up, or the hydrogen ion concentration goes down, protons are going to come off albumin and make its charge more negative. And so your anion gap actually goes up in a metabolic alkalosis because of the deprotonation of albumin. And in fact, if you carry that thought further, the anion gap will change in every acid-base disorder, simply due to a change in the pH affecting the albumin charge. And what's known is that for every 0.1 change in the pH, the anion gap will change by 0.15. So it's not a big effect, but it's just something to keep in the back of your mind. And it's a surprise to many renal fellows that the anion gap changes in every acid-base disorder, but it's because of this pH-dependent effect on the charge of albumin that you must always keep in your mind when approaching a patient. Now, the other thing about the anion gap is it's dynamic. Just like we talked about before of the carbon dioxide having an input and an output, we have the same thing occurring with the anion gap. Or just like we talked about the proton load and the kidney putting bicarbonate into the system. The same thing occurs with the anions. They're produced, but they don't just stay in the body. Let's say this is a patient with lactic acidosis or ketoacidosis. You have a proton coming in, causing the metabolic acidosis, and you have an anion coming in, changing the anion gap, but you don't have a closed system. The anion can come out in the urine. And I'll show a patient that represents this phenomenon. So you always have to keep in mind that the anion concentration that you have at a point in time, when you happen to measure the anion gap, or you happen to measure the lactate, or you happen to measure the ketone bodies, is a reflection of the input versus the output. And people always think it just reflects the input, but it doesn't. In the extreme case where the kidney was able to get rid of all the anions coming in, your anion gap will never go up, but you have a production of them. whether it's lactate or beta hydroxybutyrate. So you always have to keep in mind that what you see is not just a reflection of the production. So the severity of the ketoacidosis might be much more than you think. Is from the production side, even though the blood level only changed by a little bit, and clinicians tend to forget this all the time. Now, what about the volume of distribution? That's also something else to consider. That when you have a proton load, it doesn't all stay in your blood or your ECF. It goes into the ICF. Actually, predominantly, most of the protons go into the cells. 40% are going outside. And we can calculate how much the bicarbonate could change. I showed this equation in the metabolic alkalosis talk, but what we need to do is to calculate the volume of distribution of bicarbonate first, and then we can treat the patient accordingly based on the volume of distribution of bicarbonate, and then the two bicarbonates, the one we're trying to achieve minus our current. But remember that the volume of distribution of organic anions is less than protons. So the anion gap's always going to go up. For the same input, we have the same amount coming in of each. The anion gap or the anion concentration is always going to go up in the blood more than the protons, because the protons are distributed in a much bigger volume. And people forget that, especially when this equation is taught, that you could calculate the original bicarbonate by taking the change in the anion gap and adding that to the current bicarbonate. People love to do this, where, the anion gap changed by 7. I'll add it to my now, current bicarbonate, and I'll get the original. But that assumes that they're both changing equally. And that's not true, as I said, because the anion gap typically would change more if it's just the volume of distribution. This assumes the volume of distribution are the same, which they're not. It also assumes that the rate of new bicarbonate generation on the excretion side here, that rate of new bicarbonate generation, or you could think of it also, if you want, as the rate of proton excretion by the kidney, is equal to the rate of anion excretion. And that's not necessarily true either. In fact, as I mentioned, the volume of distribution of protons is greater than anions, and therefore the change in bicarbonate based on this alone should be less than the change in the anion gap. And in addition, the excretion of anions differs. The excretion of lactate is much less than ketone bodies for the same load, just because we have transporters that can reabsorb the lactate from the glomerular filtrate, whereas the reabsorption of ketone bodies is less efficient. So in ketoacidosis, the enhanced excretion counteracts the volume of distribution effect, and empirically the ratio of the change in anion gap to change in bicarbonate is about 1:1. But in lactic acidosis, the excretion is very low, and you can have a change in the lactate concentration of 1.6 times the drop in your bicarbonate. And that is normality. It doesn't mean there's something else going on. So these kind of subtle effects you have to keep in mind when you're comparing the change in anion gap to change in bicarbonate. Now, what about the urine anion gap? It's used to estimate ammonia. And it's because when we do this, we don't include bicarbonate just because it's so low in the urine. These are the major charges. It's equal to the anion concentration minus the ammonia concentration. Now, normally it's plus 20 to plus 90, a wide range. And when it gets into this negative range, you can say possibly that there's more ammonia in the urine. But the important thing, it's not quantitative. It's all over the place. And people have stopped using this, even though it might still be on your boards. Clinically, you should never use it. Plus, if you have increased organic anions in the urine, such as ketone bodies, lactate, or hippurate, whatever it is, that's going to make this more positive, and it's going to mask. It won't be as negative as it would be because of the increased ammonia, and it can look normal, even though you've got a lot of ammonia there, just because this went up and this went up, and the difference is now back to normal. So it can mask ammonia being in the urine when you have organic anions. So people then started looking at the urine osmolar gap to estimate the ammonia, and what you do is you calculate the urine osmolality 2 times the sodium in K plus the contribution from urea plus the contribution of glucose. Those are the major osmols in normal urine, and you subtract from that the measured, and the normal is about 10 to 100. What it represents is ammonium chloride, and non-chloride containing salts. So it represents ammonia chloride and ammonia other anions. And so if you divide this by 2, this gap by 2, you'll get the ammonia concentration rather than the ammonium chloride and ammonia non-chloride concentration. You divide it by 2. And that's supposed to be a better assessment of what the ammonium concentration is. It assumes that all the sodium and K salts are completely dissociated, because if they're not, this is going to be an erroneous number. And also, it's important to realize that if you have an infection with urease-containing organisms like protease, the urea will be broken down into ammonium and bicarbonate and alter your numbers. And also, you can have other osmoles like methanol, ethylene glycol, mannitol affecting the gap, and you're not going to realize that if you're unless you're aware of them. The best thing is to measure the ammonia directly. I'm trying to get that set up at UCLA. There are some health systems now that are allowing the measurement of ammonia in the urine. It's surprising since it's been measured in blood for decades. Of course, the range of the assay is different. The urine is in millimolar concentrations, whereas the blood is in micromolar. Okay, so let's take a patient here. This is a 27-year-old female. Does anybody want to take a stab at this? Again, let's start with the acid-base diagnosis. You look at the bicarbonate or the total CO2, and you see the total CO2 is only a little bit higher than this. So does anybody want to come up with, first of all, the acid-base diagnosis? No? Okay. So the bicarbonate's down. So we're either dealing with a metabolic acidosis or an acute or chronic respiratory alkalosis. Then we look at the change of the PCO2 to change in bicarbonate. And we can see that of those 3, the only one where the ratios work out what we predict is a metabolic acidosis that's compensated. And so this cannot be acute respiratory alkalosis or chronic respiratory alkalosis. Then, if it's a metabolic acidosis compensated, we look at the anion gap. So the anion gap is 131 minus 110. So it's elevated. The glucose is 600. So we might be thinking, and the patient looks a little volume depleted. There's some pre-renal failure here, most likely. And then the patient got saline, the renal function got better, so we probably were correct. The total CO2 didn't change much, but look at the anion gap now. The anion gap has decreased. It's now 107 plus 17 from 135 compared to what it was before. So what's going on here? Well, what's going on, and we typically see this, is that we improved our renal function so that the kidney can now get rid of the organic anions more easily. And we've converted an anion gap metabolic acidosis to a non-gap acidosis, not because we have diarrhea or RTA or anything else. We have the same process making ketone bodies, but now the kidney is able to get rid of the ketone bodies. And that has nothing to do with correction of the metabolic acidosis. In fact, it could make the correction worse, because one of the ways the metabolic acidosis is corrected, independent of a doctor, is that the organic anions, the acetoacetate and beta hydroxybutyrate, are converted into bicarbonate. And the fact that you're getting rid of them in the urine might get rid of your anion gap elevation, but you're also slowing down the correction of the ketoacidosis. But this is just an important teaching point, that the anion gap in ketoacidosis is not only dependent on the production of ketone bodies, it's extremely dependent on your renal function. And if you have normal renal function from the get-go and you're not volume depleted, you're going to have an anion gap that's close to normal despite a rip-roaring ketoacidosis. So that ketoacidosis can present with an elevated anion gap and to the extreme a normal anion gap, just depending on your ability to excrete those organic anions versus the production rate. If this was a lactic acidosis, it would be independent of the renal function to a large extent because the lactate is extremely efficiently reabsorbed back into the bloodstream. And so the anion gap is not dependent as much on the GFR. Whereas with ketoacidosis, there's not a good reabsorption in the nephron, and the magnitude of the filtration of the ketone bodies is what determines its excretion. Once it gets through the glomeruli, it's really not absorbed, the organic anions. Okay, so remember, ketoacidosis, the anion gap can be anything. And also, conversely, never use the anion gap or the lack thereof to assess the severity of the ketoacidosis. As I said, you can have a rip-roaring ketoacidosis and an anion gap that's only up a little bit or not at all. If your anion gap is not up and there is a rip-roaring ketoacidosis, it means your patient is volume replete and does not have pre-renal failure, even without looking at the BUN and creatinine. You know that. And you will find the ketone bodies in the urine. Even though the blood will be negative, the urine will be very positive. That just confirms your understanding of the physiology. Okay, what about this patient? It's a 25-year-old male who was glue sniffing. Let's just look at the blood chemistry. You can see that the bicarbonate's 14, total CO2 is 15. So again, it's down. So again, the same thinking. Is it a metabolic acidosis or acute or chronic respiratory alkalosis? Again, we look at the PCO2 change from normality versus the bicarbonate or total CO2 change from normality, and you can see the numbers only fit a compensated metabolic acidosis. Okay, well, the anion gap here is normal, so we're starting to think, well, maybe it's a GI cause. Going through all the GI causes, the most common would be diarrhea. Maybe it's some rarer thing involving the GI tract, like a gallbladder fistula, that kind of thing. Or maybe it's renal, maybe the patient has RTA. Well, we look at the urine and the pH is 6.8. The urine anion gap is plus 15. It looks pretty normal. However, the urine osmolar gap is plus 300. It's very high. So what's going on here? Well, the clue is that the patient is glue sniffing. And glue sniffing creates a proton with hippurate. So this could be a board question. The hippurate would tend to raise the anion gap, except that the hippurate's very nicely excreted. And so you end up having the hippurate go in the urine, normalizing the anion gap, even though it is called an anion gap metabolic acidosis. The pattern in the blood is non-gap because the hippurate was excreted. So you always have to distinguish the cause of the acid-base disorder, which is how we define whether it's gap or non-gap, versus the pattern in the blood, which can be discrepant from the cause, depending how much the anion is excreted. So just like the ketone bodies, hippurate can be excreted and your anion gap in your blood can normalize, even though it is causally an anion gap metabolic acidosis. So you have to make that distinction of the cause versus what the blood shows. Now, the hippurate will go into the urine and will raise the organic anion concentration in the urine, and that's why our urine anion gap is plus 15. Even though there's a lot of ammonia there, it's not negative like you would expect, because remember, it's the organic anion concentration minus the ammonia concentration that determines this, and if they're both elevated, this will fall into the normal range. The clue that we have ammonia in the urine is this elevated urine osmolar gap. And just simplistically, we can divide this by 2, and that means the ammonia concentration in the urine is around 150 millimolar. Okay, here's a male who is vomiting. Again, we look at the bicarbonate or total CO2. It's elevated, so it's either a metabolic alkalosis or it's acute or chronic respiratory acidosis. We look at the change in PCO2 from normality versus the change in bicarbonate, and this only fits a metabolic alkalosis compensated, where for every 10 increase in the bicarbonate, the PCO2 goes up about 7. Remember, in vomiting, we have a gastric cause where we have excessive protons being secreted into the lumen of the stomach in exchange for a potassium ion. This is an ATPase, but the proton came from carbonic acid ultimately. Therefore, every proton that's secreted creates a bicarbonate ion, which leaves the cell on this chloride bicarbonate exchanger on the basolateral membrane of the parietal cell called AE2. Again, this is what happens with the so-called alkaline tide when we eat, or excessive vomiting. Omeprazole or other compounds that will block this proton pump will ameliorate the process. But again, as we talked about in the metabolic alkalosis lecture, we have to also think not just where the bicarbonate came from, but why it's not being excreted. And this just shows some of the sites. Patients can be volume depleted, so they have a lower filtered load of bicarbonate coming through. The proximal tubule is hyperabsorbing any of the bicarbonate that gets through, stimulated by angiotensin II, and also the sympathetic nervous system. And we have less bicarbonate secreted into the connecting tubule and the cortical collecting duct via pendrin. So all these things help keep the bicarbonate elevated. And the therapy is to give chloride. We correct the GFR, we shut off the proximal tubule, and we allow pendrin to secrete bicarbonate into the urine. This process being the most important, as I mentioned before, because you can still have pre-renal failure, be volume depleted, still have a high A2 level, and yet the metabolic alkalosis will recover because you've allowed chloride to get into the connecting tubule lumen and the cortical collecting tubule to be exchanged for bicarbonate. And again, remember that pendrin is a key component of correcting the chloride-sensitive metabolic alkaloses. It's in the so-called beta intercalated cell here. Okay, here's another patient with heart failure on Lasix. Again, bicarbonate elevated. Again, it's either metabolic alkalosis or acute or chronic respiratory acidosis. Again, when we look at these changes with PCO2 and bicarbonate, they only fit a compensated metabolic alkalosis. And again, realize we're never looking at the pH in any of these things that we've talked about. We don't care what the pH is. If it's metabolic alkalosis, we assess the urine chloride. Here it's normal, so this is a chloride we can give as much chloride as we want, and nothing's going to happen to these numbers. Now, Lasix or diuretics are confusing because if they're still on the diuretic, they're chloride non-responsive. Once the diuretic is stopped, they become chloride responsive. So it really depends on whether they're still actively taking it or not. Here's a 60-year-old male, elevated bicarbonate. When we look at the PCO2, though, this is not metabolic alkalosis compensated. This only fits chronic respiratory acidosis, one of the three. Okay, but if you just looked at the total CO2 here, you'd say, oh, this is a metabolic alkalosis, but you'd be wrong. Again, we don't care about the pH as far as its importance diagnostically. Now, when we have an elevated PCO2 chronically, we also calculate what's called the A gradient because it allows you to predict what the clinical cause is of the chronic respiratory acidosis. In this case, we're calculating first what the PO2 is in the alveolus. The patient was breathing room air, so we're using 150 here, minus 5/4 of the PCO2. The answer is 60. When we subtract 50 from 60, we get 10, which is normal, and that helps us rule out certain conditions in the lung, and this is most compatible with chronic respiratory acidosis due to chronic bronchitis, which I'll show in a minute. As far as what's happening here, we have a step change in the PCO2, and what happens is the bicarbonate doesn't go up immediately, it slowly goes up. And here we call this acute respiratory acidosis, and finally here after a number of days we call it chronic respiratory acidosis. We don't have a term for in between. We don't call it subacute or subacute, even though we could. We only assess the beginning or the end. If it's in the middle, it could be not necessarily a mixed disorder, but that your patient just hasn't reached the chronic level yet, because this bicarbonate is changing over days at the same PCO2 of 72. That's the point, until it finally stops changing. But the reason for knowing the AA gradient is to distinguish the so-called blue bloater, chronic bronchitic, from the pink puffer of the emphysematous patient. This patient has a chronic respiratory acidosis and a normal AA gradient. These patients tend to have a chronic respiratory alkalosis and an increased AA gradient. So the acid-base disorder helps tell you why the patient has COPD. Okay, here's another patient, 78-year-old male, short of breath with bone pain, hemoglobin low, calcium up. You look at the bicarbonate, it's elevated. PCO2 is elevated. Again, this is compatible with chronic respiratory acidosis. And this would be a patient with multiple myeloma. This is a female in the 3rd trimester of pregnancy. Total CO2 is down, bicarb's down. Don't think metabolic acidosis. These two numbers are not compatible with that. The PCO2 has dropped twice as much as the bicarbonate fell. You never see that in a compensated metabolic acidosis. This is only compatible with chronic respiratory alkalosis, which all females in the 3rd trimester of pregnancy have. Of course, this could be a cirrhotic patient, or it could be people that live in Denver, Colorado at high altitude. They have the same numbers. But the most common reason on the earth is women who are pregnant. And so this becomes your new norm. Again, a step change in the PCO2 down, the bicarbonate falls gradually. We call this acute respiratory alkalosis. We call this chronic respiratory alkalosis, and we do not have a term in between. If you happen to catch the patient here, you might misdiagnose everything as a mixed disorder because it doesn't fall into acute or chronic respiratory alkalosis. But if you wait long enough, it'll become chronic. But you can be confused in the middle here. Here's a 36-year-old male with anxiety. Bicarb's down a little bit. PCO2's down more. Again, don't call this a metabolic acidosis, even mild. These numbers reflect the ratios of change from normality are only compatible with acute respiratory alkalosis. Now, there are other clues in respiratory alkalosis in that you develop hypophosphatemia because the elevated pH in the cells stimulates glycolysis, stimulates phosphofructokinase, and that causes the glucose to fall. And I think I will stop there and take any questions that you might have.
Hey, Dr. Kurtz, it's Nolan. I had a couple questions, if you don't mind. The first one, I just wanted to get your sense, like it may not matter, but for when you calculate the anion gap, would it be more correct if it is so to use the calculated bicarbonate from a blood gas or a measured total CO2? Or does it not matter because they're similar?
It's more correct to use the bicarbonate because remember the total CO2 includes non-charged substances. Remember that the bicarbonate in the total CO2 is charged, but the dissolved carbon dioxide that is contributing to the total CO2 is not charged. And so if you use the total CO2, you are erroneously changing the actual charge.
Got it.
So you should always use, now if the PCO2 is 40, which means the carbon dioxide that is neutral and not charged is only contributing 1.2 millimolar to the total CO2, then your error is going to be very small. It's only going to, you're only going to be off by 1 millimole per liter or 1 milliequivalent per liter. But if your PCO2 is 80 or 90, you know, you have a severe respiratory acidosis, then you're going to think that the total CO2, which is now 2 to 3 millimoles per liter higher, is reflecting 2 to 3 millimoles per liter of one negative charge more. Your anion gap is going to come out, you know, less than it really is.
Got it. So when the PCO2,
always bicarbonate. But if the PCO2 is normal, makes no difference.
Got it. That's helpful. Thank you. And then I just want to make sure I heard you correctly. When there is a like the I don't want to say primary, but when the main disturbance, I guess maybe that's correct, is a respiratory issue, we don't use the term compensated in terms of like using for the metabolic component, right? Only if there's a metabolic with a respiratory component.
Yes. So what could have evolved historically, which didn't, is that we would call chronic respiratory acidosis a compensated respiratory acidosis, and we would call chronic respiratory alkalosis a compensated respiratory alkalosis, but that never evolved.
Got it.
So we just call it chronic.
Okay, understand. And then if you don't mind, I had one more clinical kind of scenario that I was put in, and I just wanted to get your sense. So it was actually last night. There was a patient who came in. He has end-stage kidney disease and heart failure, and he had a venous blood gas that was 7.15. By CO2, PCO2 was 57, and the calculated bicarbonate was 19.9. But on the basic metabolic panel, the total CO2 was measured to be 14. So based on that, which is impossible, right?
Yes, and
right.
that occurred in the patient that we presented with the metabolic alkalosis.
Right. Which I wanted to get your sense.
Impossible. There might be something going on, and assuming they were both venous.
Yeah, assuming, right? I mean, they were reported to be.
Yeah, one of the numbers is wrong, and it might be something worth maybe talking to the clinical lab about, because if this thing is occurring all the time, they have some systematic error in the measurements. But chemically, it cannot be. The total CO2 includes bicarbonate, carbonate, carbonic acid, and dissolved CO2. You cannot have a bicarbonate that's higher than that. It's only one of the 4 components.
Right. Aside from a measured error, there's no other clinical scenario that could be possible in?
Not that I'm aware of.
Okay. Yeah, I handed off the patient in the morning, but I did follow up on a repeat blood gas after I think that the patient was put on BiPAP or something. And I think it was like 7.17, 52, so a little bit lower PCO2, with a measured bicarbonate of measured bicarbonate of 18, I think. And again, the total CO2 measured was like 12 or 13. So still not
same story, just different numbers, but still still the same phenomena.
Okay. So in that scenario,
that's very, very interesting.
Yeah, in that scenario, do you I mean, maybe you don't, maybe it's impossible to say, but is there a number that you would kind of go off of?
Yes, I mean, usually the pH and the PCO2 are measured correctly. It's very rare, in 2022 that the pH electrode and the PCO2 electrode are not calibrated, or there's something wrong with the machine. So I would intuitively, unless there's something, with that healthcare system or their clinical lab, go by the calculated bicarbonate.
Okay, so that's good to know, just in case, obviously we would need to have the knowledge to talk to the clinical lab, which was our lab, by the way. It was here at UCLA, but but kind of ignore, maybe that's not the right term, but really query the TCO2, because that's just not possible. Yes, I would query both, but if you're going to Las Vegas as to which is more likely the real number, I would say the calculated blood gas is most likely the real number. I mean, the other way to do it is to get arterial and venous, just to see, because this phenomenon so far that I've seen, it tends to be venous. I'm not sure why that is. I don't know if you've seen the same thing on the arterial side. No, I haven't. In fact, it's probably one of the few times I've ever seen it. So yeah, I'm glad that we had this lecture today. It was, serendipitous. Yeah, I think it's something really worth talking to the clinical labs about. I can help you with that also. But yeah, I think if this is occurring a lot, there's something going on that needs to be fixed. All right. Well, certainly we'll be on the lookout. So thank you again very much for your time. This is a great lecture. You're welcome. You're welcome. Anyone else have any other questions? Okay. Well, if not, thanks for joining today, and look forward to giving you the mixed acid base lecture in the near future. Bye-bye, everybody.